Yes. Yeah, this is a good one. So it's mainly peripheral, basal, subpleural here. If you look at the high resolution CT, you'll see the subpleural involvement, right?
Is that traction?
So that's traction bronchiectasis, which is what? What is traction bronchiectasis?
Because in the fibrosis, you're gonna pull the wall of the bronchi and causing the cystic cylindrical shape.
So traction bronchiectasis is bronchiectasis or cystic dilatation of the airways because of loss of the interstitial support. What is the difference between traction bronchiectasis and the usual bronchiectasis? In these cases, you didn't have airway thickening. So usual bronchiectasis, you have airway thickening and dilatation. Okay. In traction bronchiectasis, there is no thickening of the airways. They're dilated because of loss of the interstitial support, so they get dilated. Okay. Classically in interstitial lung disease or diffuse lung disease. So treatment is usually very limited because they are non-responders to steroids. Why? Because they present at late stages with fibrotic stage. If you have fibrotic stage, honeycombing in the high resolution CT, they're unlikely to respond to steroids, right? People who respond to steroids are those who have ground glass opacities on high resolution CT, which means they still have an active, ongoing inflammatory reaction. So if you hit them with anti-inflammatory agents, they may respond. But if the inflammation is gone, there's just remnant of fibrotic changes, then probably they're not going to respond to the treatment.
So it's a healing process.
Exactly. This is like an advanced fibrotic stage now. Okay, survival is like limited at 2 to 5 years, very limited.
So Mazen,
you need to remember that. I'm sorry, just immediately finish. So steroid response is very limited. Prognosis is bad. They could be candidate for transplant, maybe. Treatment is usually oxygen when they have resting hypoxemia, or even hypoxemia on exercise. You may supply them with oxygen. If they have also nocturnal hypoxemia, you have to give them oxygen. Treat their pulmonary hypertension because nowadays we know that presence of pulmonary hypertension is a more prognostic sign in those patients. If you treat their pulmonary hypertension by vasodilator, you improve their exercise capacity and their 6-minute walk. Okay. There's one more thing. Yeah, that's it. So the next one is the NSIP, which is the non-specific interstitial pneumonitis. Non-specific interstitial pneumonitis is a kind of the same disease, which is on the other spectrum. So it's mainly in younger people. Okay, they have more of the active stage of the disease, so they have more ground glass opacities, not that much of fibrotic changes on the CAT scan. Okay. So those patients are more responders to treatment with steroids, and they have better prognosis, of course. Okay? Is it clear?
Yes.
Good. Okay. So just remember, it's a kind of a milder form of IPF. Earlier stage, respond better to steroids. Pneumonitis, yeah. NSIP. Okay. And they're usually younger than IPF patients. Okay. RP-ILD and VIP, the respiratory bronchiolitis, interstitial lung disease, and the discomated interstitial pneumonia or pneumonitis. So these two categories are actually the same disease with different, again, different stages. RP-ILD is more proximal disease, so it involves the bronchioles. Okay, so they have bronchiolitis element, and their disease is more advanced at the time of presentation. They have more fibrotic changes. VIP is more distal disease, so they have more alveolar involvement. In most of the time, they have more ground glass opacities on imaging, so they are more responsive to treatment with steroid and immunosuppressive agents. So this one is better than this one, because this one responds more to anti-inflammatory treatment. Okay. Now this entity is also strongly associated with smokers. And as I said before, RBILD is called smoker's bronchiolitis. It's associated also with cystic changes, emphysematous changes at the apices. Okay, and it is one of the diseases that has the mixed obstructive restrictive pattern, because they are smokers, they have cystic changes, they have obstructive component on top of the interstitial component, so they have both restrictive and obstructive pattern in the end. Okay, I think that's it.
The book, can you tell us more about obliterating bronchiolitis?
It's stealth. I didn't talk about it yet. I will talk. Next is AIP. We talked already about AIP, acute interstitial pneumonitis or hemorrhage. It's basically non-cardiogenic pulmonary edema in the absence of cells, right? It's a very acute onset, usually days to weeks, few weeks, usually days. Prognosis is bad. We have high mortality rate, about 50 to 60% mortality. Treatment is usually supportive. Ventilator support most of the time. And nothing to remember about. Okay. COP, which is the cryptogenic organizing pneumonia, is an interesting disease that usually presents where the subacute presentation, so they have like cough, shortness of breath, sometimes constitutional fever. They present like pneumonias initially, and they have patchy alveolar filling with also some bronchioles involved. So on imaging, they look like pneumonias, basically. So those patients classically get treated with antibiotics first, with no significant response, and they come back in a few weeks. You get the chest X-ray, again, you will see basal involvement more than apical, bilateral, patchy, alveolar, with some interstitial changes as well. And treatment is steroid. They respond very well to steroids, right? Relapse after, so this is cryptogenic organizing pneumonia. See, looks like pneumonia, alveolar filling. At the same time, there is some bronchioles involved as well. Remember, it's mostly basal, right? And as we said, it's one of the diseases that are usually peripheral. It's one of the negative or photogenic negative pulmonary edema, so it's more peripheral than central. Pleural effusion is rare. You don't see pleural effusion with cough. Okay. Another sign that you may see with cough is called negative or reverse halo sign. Halo sign is classical invasive, acute invasive aspergillosis. Negative or reverse halo sign is classic, very characteristic of cough. Okay. In the past, they used to call it BOO, bronchiolitis suppuratus with organizing pneumonia. Nowadays, they say if you have an underlying cause, because cough can be associated with connective tissue diseases, drugs, infectious etiologies sometimes. If you have something that you know, oh, this is probably secondary to drugs, then you can call it BOO, bronchiolitis suppuratus with organizing. But if you don't know, if it's idiopathic, then you have to call it cryptogenic. Some people prefer to call it just cryptogenic for everybody. So it depends. Most of the time nowadays they call it just cough, cryptogenic organizing pneumonia. Okay, but remember to look for underlying drugs, malignancy, infectious, not malignancy, connective tissue diseases, and drugs maybe. Okay. What else? LAM or LAM, lymphangiomyomatosis, and histo are kind of similar diseases. LAM is exclusively seen in females of childbearing age. They present with recurrent pneumothoraces because they have diffuse cystic changes on their cat canine. This is not a great one, but you probably can see diffuse cystic changes on the CAT scan. So when these fully rupture, they present with pneumothorax. They're young females again. Sometimes they have extrapulmonary manifestation, mainly uterine fibroids and renal lyo and lipomas, whatever. Not lipomas. Whatever. Anyway, so benign tumors of their kidneys and uterus. It is believed to be secondary to abnormal formation of thoracic duct and lymphatics. So they have chylous effusion as well. So they have chylous effusion, chylothorax, and they have also lymphedema. Or I'm sorry, not lymphedema, just chylothorax. So they have chylothorax, recurrent pneumothoraces, and cystic changes on the CAT scan. Young female treatment, and they get worse with pregnancy or estrogen therapy. So it's related to estrogen and hormones. We don't know exactly how. Treatment sometimes is manipulation of hormones, not very effective. Most of the time they need lung transplant.
Do we need tissue for diagnosis or just CAT scan?
High resolution is very characteristic in those patients. If you are in doubt, you can get a high resolution CT. You don't have nodules on the CAT scan. That's a kind of interesting difference between LAM and histo. Histocytosis X, they have also on top of the cystic change, they have also micronodular pattern. Histo is usually upper lobes. LAM is usually diffuse. Histo is mainly smokers, young males. LAM is exclusively in females. But the presentation is sometimes similar. Recurrent pneumothoraces, diffuse cystic changes on CAT scan. One of them, okay? Histocytosis, as we said, can be extrapulmonary manifestation, can be either central diabetes insipidus, very classic, hypernatremia, and they can also present with bone disease, cystic bone disease, especially in kids. And I think there was a question on endocrine mix-up, one of the mix-up endocrinology about somebody with central diabetes insipidus and I think uveitis. So two lung diseases that you have to remember for if you have central diabetes insipidus and shortness of breath, two diseases, sarcoid and histocytosis. They present with central DI. Okay? Good. One more disease called LIP or lymphocytic interstitial pneumonias. It's lymphocytic, so it's mainly seen in patients with lymphocyte disorders. Patients with Waldenstrom, very classic, multiple myeloma, lymphocytes. Patients with HIV, that's another lymphocyte disorder. Patients with lymphoma sometimes. Patients with graft versus host disease, that's another lymphocyte disorder. So if you have somebody with a lymphocytic disorder presenting with interstitial lung disease, think of LIP, lymphocytic interstitial pneumonias. Okay. It can be idiopathic or secondary. Treatment is usually treated in the line course. They have lymphoma, treated lymphoma, Waldenstrom, treated in the line course.
Tissue
That's
diagnosis.
It's a tissue diagnosis. It is a tissue diagnosis, but so let's go to the question, please. So I know it's a little bit complicated and confusing, so you have to read it. But at least I was trying to just make it at least as simple as we can.
All right. Yeah. So
We can talk about like
1 year.
a lot about
1 year about.
about interstitial.
This is what we need for
and,
the board.
and each of them needs like a separate talk, but we're just doing this for board review, so we have to go quickly. 1 minute for each question. We have 15 minutes left, 15 questions. So 1 minute for each question.
26-year-old woman with 18 months history of diffuse cutaneous cystic sclerosis. There is about 6 months history of diffuse exercise that actually otherwise healthy, takes no meds. On exam, blood pressure is okay, pulse is 80, pressure 18, cut exam is normal. The bilateral dry crackles, but no other abnormality. The skin over the digits of both hands and parts of the arms and forearm is thickened and tight. Lab study shows normal. Electrolytes, creatinine, complete CBC, and anti-scleroderma, anti-70 antibodies are positive. The function test shows FEV1 8%, predicted PPC of 76%, DLC of 80%, high-resolution CT shows scanned bilateral reticular changes with bilateral and peripheral distribution. There is no evidence of granular capacity, visual isolation to the extent that the enrollment is 10%. This is only the most management for special disease. Cyclophosphamide, low-dose prednisone, high-dose prednisone, open line biopsy, periodic high-resolution CT scan, non-function testing.
So what was the CT scan finding? Excuse me, just go back to the CT scan finding.
So here.
Okay,
class of classification.
I think to start
This is
with,
scary.
there's no role of steroids in systemic sclerosis. So,
I'm sorry, go a little bit up with the question again.
The patient
So
with
that's-
diffuse
that's it.
scleroderma with
Go,
lung.
go a little
Down, down.
Up, down, down.
that's it.
So that's
So
ED.
what is the last statement?
Visual impression is 10%.
Okay, of lung involved.
Oh, so
Go
you
to the
will
question
be
now.
CAT in
Now read the
March?
question again.
so what's the most appropriate management for this pulmonary disease?
Periodic high resolution is gonna have
Oh,
one.
we need to have a diagnosis.
So,
No.
I usually go with
now we lack the knowledge about systemic sclerosis. How
We
much
need tissue, we need tissue, I
should
guess.
The lung be involved before?
We need tissue, guys.
Before.
So just a
Yeah.
second. So
Not to start.
cyclophosphamide and prednisone treating what?
Fibrosis,
Because you said gram glance.
So,
that means it's
So steroid with cyclophosphamide is the treatment of usually vasculitis, like severe vasculitis. Usually they use high dose steroid, not low dose prednisone, but prednisone or like high dose steroids, usually pulse steroids, plus cyclophosphamide is for severe vasculitis, usually kidney or pulmonary vasculitis. Do you think this patient has pulmonary vasculitis? Do you think, what are the findings in the high resolution CT or?
D. So the answer is D.
gram
Yeah,
glance.
yeah.
let's get
I
another
think so.
So the question, 10% of gram glance appearance with this.
No, just
Is it
High resolution
is it not
CT
enough?
shows scanned bilateral reticular changes.
This is the question. Is it enough or?
so you have just few
Yeah.
fibrotic changes, right?
Like full up, like.
but this is an active systemic sclerosis with
periodic.
Either C or
Let's
D,
go
I
follow
think.
up. No, follow up.
Let's follow up.
Periodic.
Yeah.
Go
Is
to
it
the key
D?
answer now.
Is that
Just key
right
answer.
or wrong?
Right,
Agree.
right. Just. So
So pulmonary disease occurs in 30% of patients with systemic sclerosis and is the primary cause of mortality. This is not
Okay.
an answer.
Okay, go down, go down.
That is
So you're looking for biopsy for what? To know that this is interstitial secondary to scleroderma?
But we know that.
That's we know that this is
I mean, we assume
scleroderma.
that.
Zoom
We
out.
are not
Right.
for sure, but yeah.
That's cheap.
Yeah, but knowing that it's a common.
Most of the
Go down,
biopsies
more,
like
more,
non-specific,
more,
right?
more.
In what?
If you get, if you see pulmonary fibrosis and you do a biopsy, what is, I don't know, what's the percentage of getting an accurate diagnosis from that biopsy?
It depends.
Because
depends on the
they will
disease,
see
it depends
just
on-
collagen and
Yeah.
some cells. and-
Just
One
scan.
moment.
Like minimum.
So it says open lung is not necessary to diagnose systemic sclerosis induced lung disease. And there is a study that showed that interstitial lung disease with systemic sclerosis is extensive, they can benefit from cyclophosphamide and steroid. But they say because this is not extensive and the PFT is not bad, so it's fine to follow.
We are talking
Next.
about the
Next.
20% of the involvement. Anyway.
Next
Yeah.
question.
Next.
It's more rheumatology than pulmonary.
51.
No, not yet.
Is this the next question?
يلا يا عيسى.
Isa.
A 44-year-old man is evaluated for a 4-month history of progressive dyspnea and cough. The patient is otherwise healthy and takes no medications. He has smoked 2 bags of cigarettes a day for 10 years. On physical exam, vitals are normal, cardiopulmonary examination is normal, pulmonary function tests show a mixed obstructive restrictive defect. High resolution CT scan of the chest shows bibasilar reticular and reticulonodular rheumatism, centrilobular distribution with the diffuse areas of ground glass ossification go down, which is the following is the most likely diagnosis recent history, right?
We have
What are the 4 that I told you about?
histocytosis X,
Okay.
sarcoidosis,
Okay.
and the respiratory bronchiolitis interstitial fibrosis, and the last one
Lamb.
is
Lamb.
lamb.
Okay. So which one is the answer?
Crypto.
D.
Okay, you have to now. One moment. What's the pattern? What's
So crypto. No,
D is the answer.
COP is restricted in 80% of patients.
Ah.
20% they have obstructive,
Okay.
but it's not mixed.
Okay.
Okay.
It's good to know.
And this pattern actually is mixed.
Okay.
Like RPILD with some DIP as well. Right. But at least, and you remember the patient has to be a smoker. Should be
Right.
history of smoking.
And he's more.
He's a smoker. Next.
Somebody read quickly.
Typically, albuma is evaluated for a 3-week history of gradually increasing dyspnea and microlactic cough with intermittent fever and severe fatigue. The patient was diagnosed with CMN 2 months ago. She has no previous history of lung disease. Meds include physical exam. Temperature is 100.
You don't know how to drive this.
It is 110/78, pulse 96, respiration 22, O2 stats 92.
Just use the arrows, please.
Use the arrows, right.
Glucose and eosinophilia. Chest X-ray shows new interstitial and alveolar infiltrates, chest CT, lung glass activation, and irregular reticular lines distributed in the middle and upper lung zones bilaterally. Bronchoscopy and BAL 5 days ago showed no evidence of bacterial, fungal, or viral pathogens on hair and culture. Transbronchial biopsy revealed a pathologic diagnosis of organized pneumonia. Which of the following is the most appropriate management for this patient?
Discontinue.
Yeah, I would do
Secondary to
Remember we said it could be secondary to medicine
yeah.
or infectious etiology or
Yeah.
what? Connected tissue disease.
Which
right?
one? Yeah.
There's no connected tissue disease, no infectious etiology identified, all cultures are negative.
Organizing.
There's a new medicine added, which is mathematics. Step is stop.
Yeah, most of the time stop medication is the right answer.
Thanks to you.
Only assurance.
Valuable addition.
Only assurance.
Yeah, it's valuable.
It is
It is very valuable.
Next.
Can you please do an EKG?
Yeah, she just no, not really.
Sally is
Can you do a
is
EKG
evaluated
on
for
her?
1 year history of
Okay.
progressive dyspnea and dry cough. She has had previous evaluations for the symptoms and has had abnormal chest X-ray and 5 resolution CT scans.
Oh, she's
She
here.
also has a history of arterial systolic hypertension, Sjogren's syndrome, and monoclonal gammopathy.
So that's a second. So Sjogren's syndrome is what?
It's
Conjunctive lung disease.
dryness.
That's correct.
Yeah.
Autoimmune.
Gives it dryness.
Autoimmune of what? What cells? involved?
Lymphocyte immune. Lymphocyte, so now.
That's why Sjogren, they have rare tendencies to develop
Exactly.
lymphomas, right?
Exactly, you don't have to wait till
And you have gammopathy, so it's lab.
So,
Lymphocytic infiltration.
Lymphocytic.
Lymphocytic.
LIV.
so just a second. Ahmed will answer this question. He will answer it wrong, I'm sure. Go down.
Where is this?
Where was it? Just you have 5 seconds, Ahmed. What is the answer?
You don't have to continue. Children.
So it's the connective tissue disease of
An lymphoma.
A or B?
It's A.
Not B.
No, because you have Sjogren's syndrome. It's secondary to connective tissue disease.
Excuse-moi.
Because it's not endemic. We have that.
Okay, so remember lymphocytic interstitial pneumonia is secondary to lymphocyte disease. So they give you like organs from monoclonal gammopathy or Sjogren's syndrome, any lymphocyte disorder, HIV. Remember lymphocytic interstitial pneumonia. But it's secondary, not primary.